It's my pleasure to introduce our speaker today, Dr. Janie Sabla, who's um, acting assistant professor in the division, mostly practices Harborview, but does some work at Montlake as well. Janie joined our group in 2019. She is originally from Arizona, but did her undergraduate and medical training at Boston University. She did her residency at UCSD, followed by cardiology fellowship at University of Texas Southwestern, where she developed an interest, or she continued her interest in basic science and cardiac biology. She worked in the lab of Dr. Hesham Satek, which many of you probably know is one of the leaders in the field. She's well published with publications in Nature, a co-first author in Nature Metabolism, Circulation, TNS, and has been supported through intramural and extramural funding. She has an interest in genetic cardiomyopathies and sees patients with those conditions here. And in terms of her other involvement, she's involved in the AHA, assistant editor of social media for circulation and the guidelines of ambassador. And she's a good Twitter follower. So she tweets out often about important studies. And she's going to talk about a very interesting topic today that I know it's come up at least twice in the last week for me in my practice. Are fat diets bad diets? So I'm looking forward to hearing her talk today.
All right, Fareed, thank you for the kind introduction. I realized I probably picked a good topic with the number of emails and texts I got after the announcement went out. And though maybe it would have made more sense for me to talk about genetic cardiomyopathies today, this is a topic that frequently comes up in my clinic practice, and I'm realizing is coming up for a lot of you guys as well. So just to get started, I have no disclosures that are relevant to this talk, but I do have some disclaimers. And the first is that I'm not a nutrition expert, but as I mentioned, this topic does come up frequently in my personal practice. And in speaking to a lot of you, this also comes up quite frequently when we're seeing patients across the various sites here. This is a pretty broad topic, so to try to keep this focused, I've limited the scope to just assessment of cardiac risk factors. And it's important to mention that some of these diets have been linked to improved outcomes for other conditions, so specifically things like epilepsy and other neurologic conditions, in addition to cancer, kidney disease, GI conditions. And I'm probably missing a number of conditions which have shown some benefit for various diets. And then much of the data in this space is not great, to put it bluntly. It's derived from observational studies or from really small randomized trials. Additionally, there's no standards for diet protocols in this space, so it's very hard to compare study to study. But over the course of the next hour or so, we'll try to do our best to get through the data that does exist, and I tried to pull out some of the higher quality evidence. So to start off with a case, this is someone I saw very close to first starting at the UW, and it's a 49-year-old man who presented to general cardiology clinic for further management of coronary artery disease. He had no sort of symptoms, no chest pains or exertional shortness of breath, but it noted that his job made him largely sedentary, and he was walking for about 30 minutes a day at that time. And he had recently switched to eating a largely plant-based diet, which is a diet that his wife had been on for some period of time. So in terms of his past medical history, he had been diagnosed with coronary artery disease by CAC scoring. So he had a CAC score done in 2015 with an absolute value of 71. And he had a repeat study done in 2018, which showed that the absolute value had increased to 188. And both had sort of put him in a high risk category. And then he also had been diagnosed with hyperlipidemia and had a recent diagnosis of prediabetes, which was based off a hemoglobin A1C of 5.8%. In terms of medications, he was on rosuvastatin, 20 milligrams, and he had a 10-year history of statin use, and his dose had sort of escalated over time. And then for his objective data, in clinic, his BMI was a little bit higher than we would like at 26. His hemoglobin A1C was indeed 5.8%, which gave him that diagnosis of prediabetes. His LDL was actually pretty good on Rasuva 20 and was at 61. And then he had an LPA level checked prior to this clinic visit, which was a bit elevated and returned at 78.5, and certainly is a risk marker. And we'll hopefully get more data shortly on whether or not this should be a target for some of our future management. So after this visit, he had largely asked for additional testing, which included some specific genetic testing. So we had him come back, come back 2 months later to follow up on his test results. And at the time, he mentioned that he had been doing some research on diets at home and had been considering starting on the carnivore diet, which we'll get into a little bit later during this talk. And so some of that repeat testing included remeasurement of his weight and BMI, and he actually had lost some weight in between these visits, and his BMI was now just under 25. His hemoglobin A1C had improved, and it had returned at 5.3%. His HDL cholesterol had also improved to 46. His LDL cholesterol maybe had gotten a little bit worse, but was still close to what we would consider a good goal for him at 76. And then after this visit, I did see him 2 more times. I think the most recent visit is most relevant to this talk. So he had increased his walking. So I saw him about 2 months ago, he had increased his walking to 3 miles twice a day. He had actually stopped his statin as he felt like it was contributing to him developing diabetes. And he had assessed that by doing continuous glucose monitoring at home. So he had done a number of tests on himself on the statin and off the statin, and felt that his CGM values were much better off the statin. And then he had actually fully modified his diet to the carnivore diet, which again, we'll talk about later in this talk. So the fact that he was on the carnivore diet led me to ask the following question, which is, are these fad diets really bad diets? So over the course of the talk today, we're going to review lipoproteins and their associations with cardiovascular disease. We'll go into a brief discussion of hyperglycemia, of diabetes, and its relationship to cardiovascular disease. And then we'll review the impact of 2 important and popular fad diets on cardiovascular risk factors. I'm going to start with the keto diet and then move on to intermittent fasting. And then we'll do a case summary. So when we're talking about lipoproteins, we're really talking about transport mechanisms for cholesterol and for triglycerides. And that's because cholesterol and triglyceride are insoluble in water. So they need help to get to various parts of our body. And they're important components of cell function. So cholesterol is an essential component of the of the cell membrane, and it's a precursor for bile acids, for hormones, and for vitamin D. And then triglycerides are a major energy source. They also aid in absorption and transport of fat-soluble vitamins. So the liver is really the key organ for metabolism and regulation of our plasma cholesterols. So cholesterol and triglyceride are derived from 2 primary sources. The first is exogenous, so that's what we take in, and that's absorbed through the gut. And then the second is endogenous, which is what's produced in the liver. And so the liver can package both cholesterol and triglyceride into a molecule known as VLDL. And those VLDLs can then circulate and then provide cholesterol and triglycerides to various cells in the body. And they're converted to ILDL and LDL by lipoprotein lipase and CETP. And then those LDL are then taken back up by the liver through the LDL receptors. So the liver is responsible for both production and then clearance of this particular set of lipoproteins. But LDL can also do some other things, which is it can be involved in a process known as atherogenesis, which we're all very familiar with. And so LDL is not the only player in this process. So any protein that has an apolipoprotein B on it can basically enter the arterial wall. So that includes chylomicron remnants, VLDL remnants, LDL, and then amongst a couple other lipoproteins. And when they enter the arterial wall, they can actually become oxidized, which then promotes inflammation and drives injury to the endothelium and smooth muscle cells. And these can incorporate into macrophages and create what's called foam cells. And all of these together can drive a process of injury that results in atherosclerotic heart disease. So LDL is probably the most abundant cholesterol containing protein, but it's not the only one. So LDL cholesterol, which we're going to label as LDLC for the remainder of this talk, is a measurement of the total cholesterol content that's carried by LDL. But there are a few other important lipoproteins that aren't accounted for by LDL measurement alone. And so non-HDL cholesterol can account for those and is defined as the total cholesterol minus the HDL. And it represents the cholesterol content of all of those atherogenic lipoproteins. So those are all of the ApoB containing lipoproteins, such as VLDL and lipoprotein A. So we all are very familiar with the fact that LDL cholesterol is an independent risk predictor of cardiovascular disease. So this was a study that looked at the primary prevention trials, largely statin trials, and secondary prevention trials for cardiovascular disease. They plotted the achieved LDL in these trials against the reported coronary heart disease rates that were published. And so on the right side of the screen, we can see the event rates for the primary prevention trials, which are marked in blue. And on the left side of the screen, we can see the event rates for the secondary prevention trials, which are marked in red. And so the scale on these is obviously different, but in general, what we're seeing is there's a linear relationship for both primary prevention trials and secondary prevention trials in terms of LDL and risk of coronary heart disease. And with lower LDLs associated with lower risk and higher LDLs associated with higher risks. And so I think this is a concept they're all very familiar with. Another important relationship of LDL to development of cardiovascular disease is the duration of exposure. And so some of this data has been derived from not randomized controlled trials, but prospective cohort studies and then Mendelian randomization studies. So the same group looked at these various trials in these spaces, and they found that the median follow-up for a randomized controlled trial in this space was approximately 5 years. The median follow-up was 12 years for prospective cohort studies, and then for Mendelian randomization studies, the median follow-up was about 52 years. And this graph is a little bit opposite of what we're used to seeing, but on the x-axis, the magnitude, this represents the magnitude of exposure to actually a lower HDL or LDL cholesterol. And then on the y-axis, we're looking at the proportional reduction in risk of coronary heart disease. And what we find is that when you look at Mendelian randomization studies, they can look for variants that are associated with lower LDL levels. And the greater the magnitude of exposure to lower LDL, the greater the reduction in risk. And the slope of this graph is much steeper than what we see for randomized control trials. And that difference was thought to be related to the duration of exposure to LDL cholesterol. So because the median follow-up is just substantially larger, we see that the impact of being exposed to lower LDL over a lifetime is much greater. And then there's additional measurements of cholesterol that are sometimes brought in by our patients, and some of you may have ordered this. This was something I've had to get, an assay that I've had to get more familiar with over time. But essentially, we can have quantitative estimates of lipoprotein subfractions, and probably the most common one that we hear about is assessment of lipoproteins by NMR, but there are a couple other methods by which this is done as well. And I won't launch into the details of that, but I do want to spend some time explaining what these assays can tell us. So first, it can give us an idea of LDL particle number, and that's usually represented as LDLP, and it's a measure of the number of LDL particles in serum and should be shared in reports kind of as an absolute number. It can also give us a sense of LDL size. So in general, from the data that we have available, the thought is that small, dense LDL particles are worse and large, fluffier LDL particles are better. And that's because small, dense LDL particles are associated with a greater susceptibility to oxidation. They've been shown to have a longer circulating half-life, which gives them more opportunities to infiltrate the subendothelial space, and they're more prone to actually infiltrate. And then they have higher inflammatory enzymatic activity as well. So it's thought that perhaps if you have more of the large fluffy kind, those negative impacts are less. And then the other thing that comes out is sort of the LDL pattern. And so what is discussed is usually whether or not someone's more pattern A or more pattern B. And what that is referring to is where is the peak of this LDL. And if the peak is more shifted to the right of the screen, then that's more consistent with having a pattern A type phenotype, and that means that the LDL particles are larger and more fluffy, most likely, and that if it's shifted to the left of the screen, that indicates that the LDL particles are probably smaller and more dense, and that's generally thought to be a worse pattern. Sometimes when you're looking at these NMR reports, it can be a little bit confusing to really see this clearly, which is why I didn't provide any examples of pattern A versus pattern B, because I didn't find any great ones, to be honest. So oftentimes these reports will give you also an absolute value of the peak LDL size, and they should usually tell you what the cutoffs are for pattern A and pattern B in those studies. And so if you've got smaller LDL particles, you're going to end up being pattern B, which is generally considered higher risk. And if you got larger peak LDL size, you're going to be considered more pattern A, which in this particular snapshot of a report is considered optimal risk. So LDL cholesterol may not be the only predictor of risk, and there may be better predictors of risk. So this is a study from the Framingham cohort that looks at approximately 6,000 patients. They had approximately 1,000 events over 15 years. And what we see is that for every sort of subcategorization of non-HDL cholesterol, so divided as non-HDL greater than 190, for 160 to 190, and then less than 160, the different variations of LDL cholesterol did not change the relative risk of developing coronary heart disease. But amongst the different stratifications of LDL cholesterol, we find that increases in non-HDL cholesterol do actually increase your risk of having the relative risk of developing coronary heart disease. So this led the study authors to conclude that non-HDL cholesterol may be a better predictor of risk. And actually the European guidelines have included non-HDL cholesterol targets. The ACC/HA guidelines have not included those targets, but generally for moderate risk patients, the target for a non-HDL cholesterol would be less than 130. And for very high risk patients, we'd be aiming, according to the European guidelines, aiming for non-HDL cholesterol of less than 85. This study from the Women's Health Study also showed that maybe LDL cholesterol is not sufficient to assess risk fully. And we sometimes clinically, when you think about it, we do see coronary events in people that have well-controlled LDL cholesterols. So there's some unmeasured risk that's not getting accounted for in those patients. So this looked at approximately 28,000 participants in the Women's Health Study and included over 1,000 events over the study period. And what they're really looking at is whether or not the LDL-C value was concordant or discordant with other lipoprotein markers. And in black, we see that that was a percentage of people who had concordant values. So it means that if they had a low LDL cholesterol, the non-HDL cholesterol was low, or the ApoB was low, or the LDL particle number was low. And then in red, we see that they've featured the patients that had discordant values, meaning that the LDL cholesterol may have been low, but actually the non-HDL cholesterol was high. And that we see for the various other lipoproteins that they had looked at, for example, we see discordance with non-HDL cholesterol in about 10% of patients in this study. It's much larger for ApoB and then even larger for LDL particle size. And then they went on to look at the approximately 13,500 participants who had an LDL cholesterol that was below the median. And then also kind of teased those patients out into two groups, which were the discordant group and the concordant group. And so the discordant group is listed in red. So in this case, that would mean that the LDL cholesterol was probably low, but then the non-HDL cholesterol was high, or the ApoB was high, or the LDL particle number was high. And what we find is that when you compare these two groups, the people who are discordant, have discordant values, have a much higher risk of developing coronary heart disease. And that was consistent for all three of these various measures. So that means that probably LDL cholesterol is not sufficient in and of itself to fully assess someone's cardiovascular risk. So risk prediction with some of these other measurements tends to be better than what it is with LDL cholesterol. So just highlighting this in a different way. So this study, again, from the Women's Health Study, showed that LDL cholesterol had a hazard ratio of 1.74 for cardiovascular disease risk prediction, and that other measurements, though it performed better than some measurements, other measurements outperform LDL cholesterol. And things like the total number of LDL particles from NMR can be a better measure. But that is somewhat outperformed by things that are available on a standard lipid panel, like triglycerides, and then the total to HDL cholesterol ratio. So my takeaway from this data is that though we do have the possibility of getting better measurements of cardiovascular risk, in general, most of what we need and what would be important can be obtained from a standard lipid panel. So it may not be necessary to really order this additional testing, such as lipid NMR, to really account for someone's risk. And then going back to that LDL pattern, so whether the peak of the LDL is really, or the LDL size is really shifted more rightward or leftwards, LDL pattern B, which is typically thought as the worst pattern, can predict CAC, but it's not, when you start adjusting for various lipid panels, that association seems to fade. So this is a study that looked at about 300 people that were seen at Harbor UCLA Medical Center that had their LDL quantitative assessments done, but then also had underwent CAC scoring. And what they found was that amongst those who had a pattern A LDL pattern, that they had a greater proportion of CAC scores that were 0. And then those that were pattern B tended to have greater proportion of CAC scores that were greater than 100, indicating that probably had more coronary artery disease. And that association was pretty consistent across this cohort. But then once they started adjusting for things like whether or not the patients had normal lipid panels or had abnormal lipid panels, that association goes away. So again, these additional measurements, though they may predict cardiovascular risk, don't seem to supersede what information we can get off of a standard lipid panel. And then to add further confusion in this field, this is a study from the Triumph Cohort, which is looks at a cohort of patients who recently had an MI, and I believe that they're enrolled in at the time of hospitalization. And this is a multi-center cohort study with some geographic diversity. And what they did is, at the time of enrollment, looked at what pattern these participants had. And they found that actually people who had pattern B, which is depicted in the green here, actually had greater survival from CV death. So contrary to what I had just shown you, pattern B in this particular cohort was considered to be more favorable. The theory behind why they had kind of an opposite result to what we would have expected was that after someone has an MI, they're initiated on a number of medications, and perhaps the people who are pattern B have a greater response to some of those interventions, particularly statin therapy. But they were not able to prove that in this particular study. It was just an explanation for why their results differed from what we would have expected. And this follow-up period was done over 60 months. So these patients were followed for a decent period of time to look at their risk of CV death. So now that we've kind of talked about various ways to measure lipoproteins and their association with cardiovascular risk, we're going to spend a very small amount of time talking about what the relationship is between diabetes, glucose, and cardiovascular disease. So in general, the outcomes for diabetes have improved. So this is a study that looked at the National Health Interview Survey, and they linked it to the National Death Index, and they basically looked at approximately 700,000 adults and noted that there were about 50,000 patients who had been diagnosed with diabetes amongst their sample data. And in the blue, we see the representation of deaths due to a vascular cause. So cardiovascular events would be included in the blue. And over time, so looking at 1988 compared to 2010 to 2015, we find that overall vascular events that result in death have improved in this population, but as we all know, the incidence of diabetes has increasing. So the absolute number of events is still pretty high in this population because there are just more people that have diabetes these days. And then in terms of other markers of insulin resistance, those have also been shown to be associated with cardiovascular disease. So this is a meta-analysis of 65 cohort or case control studies that looked at incident cardiovascular disease in individuals who do not have diabetes. And they looked at specifically coronary heart disease and then a broader category of cardiovascular disease. And they looked at fasting glucose, fasting insulin, and then HOMA-IR, which is a measurement that involves both fasting insulin and fasting glucose. And I put the formula on the bottom of the screen here, but essentially it's a measure of the severity of insulin resistance. And what they found was that for every increase in standard deviation for the HOMA-IR value, there was a greater proportional increase in risk of developing cardiovascular disease or coronary heart disease, so that these measures, even in someone who doesn't have diabetes, can be an important cardiovascular risk predictor as well. And then I think this is a study that will surprise no one, but having elevations in non-fasting glucose levels is associated with an increased risk of ischemic heart disease. So this was a Mendelian randomization study that was performed in 80,000 individuals from Copenhagen. And they looked at variants that were associated with glucose levels. And what they found was that if you had higher non-fasting glucose levels, which is depicted in red, and you compare it to people who had lower non-fasting glucose levels, with the lowest values being depicted in blue, that the people with higher values had higher cumulative incidence of ischemic heart disease. And I think this is consistent with data that we're all very well familiar with in the space, which is that having diabetes or being pre-diabetic is associated with an increased risk of cardiovascular disease. So now that we've kind of talked about what is the impact of lipids and what are the impacts of diabetes or markers of insulin resistant and cardiovascular disease, I want to get into the specific topics of these fad diets. And so the first question is, what is the effect of the keto diet on cardiovascular risk factors? So just as a review and to get us all on the same page about what the keto diet is, the keto diet essentially limits the daily carbohydrate intake, and carbohydrates are limited to 20 to 50 grams and accounts for 5 to 10% of the total macronutrient intake. And then the large percentage of the intake comes from taking in dietary fats, and then proteins account for the remainder. So dietary fat intake accounts for 70 to 90% of the macronutrients in this particular diet. And generally, like a standard keto diet prioritizes whole foods. And so this picture is kind of a good representation of foods that would probably be allowed in a keto diet. Generally, the keto diet is thought to have increased satiation from protein-rich foods, and that the ketosis that's generated by this diet, and we'll kind of go into that in the next slide, drives appetite suppression, and that there's actually a diuretic effect with starting this diet. So the keto diet basically shifts energy utilization. And so carbohydrates are a primary source of energy production. And when the availability of carbohydrates or glucose drops, ketogenesis begins to provide an alternative energy source. And this process usually takes like a 2 to 7 day type process to occur in the body, and oftentimes is associated with a set of symptoms known as keto flu type symptoms. So the low blood glucose feedback reduces stimulus for fat and glucose storage. And then those fatty acids are then metabolized into ketone bodies, which are then easily utilized for energy productions by cells that have mitochondria. So those cells exist in important organs like the brain and the heart. And then ketone bodies tend to produce more ATP in comparison to glucose. So this is generally considered an efficient fuel source, and can give the body the ability to maintain efficient fuel production during a calorie deficit. And then ketone bodies are thought to decrease free radical damage and enhance antioxidant capacity, which is maybe another benefit of the keto diet. So it's hard to talk about the keto diet without talking about some of the variants, because a lot of people, this can be a difficult diet to adhere to. So some people do things to make it a bit easier for themselves. So we talked about the standard keto diet. Some people participate in a targeted keto diet where they allow for increased carb intake for workouts. And then Probably a bit more common would be someone that participates in a cyclical keto diet. So this is where they rotate between high carb and low carb days. And I think you can see many variations of this. It could be done on a daily, weekly, or even monthly basis. Then there's also the lazy keto, which involves only tracking your carbohydrates and not tracking your fats and your proteins. And then dirty keto, which I suspect is probably the most common and easiest way to do this. And the dirty keto allows for processed foods. So you can, I mentioned on the earlier slide that it was largely a whole food based diet, but this allows for processed foods, which makes it a little bit easier for some people to adhere to. And then a version of the keto diet that I feel like I've been hearing about more and more is the carnivore diet. And that's essentially a plant elimination keto diet. So it's all of the food is derived from animal fats and proteins. And the carnivore diet is, I think, first really talked about in this book by Sean Baker. And perhaps why we're hearing about it more often is because Sean Baker had gone on some podcast rounds, and he had actually had a feature on the Joe Rogan Experience. And for those of you who aren't familiar with this particular podcast, it's probably the most popular podcast out there. So Joe Rogan just struck a deal with Spotify, and so his podcast is no longer available on your Apple Podcast app and has not been available since December. And so according to Spotify, the Joe Rogan Experience was the #1 podcast globally in 2020. And I just looked on my phone last night, and despite not having the ability to download any new episodes since December, he's still ranked in the top 20 podcasts on the Apple Podcast app. And so Joe Rogan had an episode about this carnivore diet, and he actually went on the carnivore diet himself for about a month. It's not something he felt like he could adhere to due to some development of diarrhea, but in general reported that he felt pretty good for the majority of the time that he was on the diet. So getting into sort of the nitty gritty of does keto work or not work, the keto diet appears to be effective for short-term weight loss. So this is a study that was conducted at Duke University, and they actually screened about 1,000 participants, but recruited 120 and randomized them to what was considered a standard diet at the time, which is the low-fat diet. The study was published in 2004 to give you context, and it was compared to a low carbohydrate diet. And at that time, the diet that had been popular was sort of an Atkins style diet, but the Atkins diet and the keto diet do have some similarities. So I think some of the data can be used to assess whether or not the keto diet is effective. And then both groups had group meetings, they got dietary instruction, and they got exercise recommendations throughout their participation in this study. So the low-fat diet is depicted in green, and the low-carb diet, which is close to the keto diet, is depicted in blue. And what they found was by week 2, approximately 90% of the participants in the low-carb diet had detectable ketones, and that did decrease by 24 weeks into the study. But both groups experienced significant weight loss, but there was a greater weight reduction in the low-carb group. This is a very busy slide, but just to summarize it, other studies have shown weight loss on a keto diet. And so this is a meta-analysis of the keto diets. Because of the general lack of evidence in this space, they did include randomized controlled trials. They included prospective cohort studies, and then they included observational studies. And I tried to mark which ones were which on the left side of the screen. Some of these studies had no comparator arm. And for this particular meta-analysis, what they were really comparing was a low carb ketogenic diet versus just a low carb diet in general. And so some of these arms, some of these studies did have a control arm, and that was the comparator. There was no variation amongst that. And what we find is that for the studies that had a ketogenic phase that lasted less than 4 weeks, there was statistically significant weight loss seen when you pull the data. And then also for studies that had a ketogenic phase greater than 4 weeks, weight loss was also seen there as well. So the general weight of the evidence suggests that short-term weight loss is certainly demonstrated on the keto diet. But what is the impact of the keto diet on lipoproteins? And I think this is an area of more controversy. So this is a study that was published in the New England Journal of Medicine. It was looking at the time at the Atkins diet versus a standard diet. The study was published in 2003. So again, the standard diet is defined as a low-fat diet. The initial phase of the Atkins diet is very similar to a keto diet. The difference is that the Atkins diet gradually allows you to increase your carb intake. So for the purposes of this slide, I really just focused on the data from the first 3 months of the study, which is when the diet's most similar to keto. This group enrolled approximately 30 people into the low-fat arm and 33 people into the low-carb arm. And approximately 77% of patients completed the first 3 months of the study, and then there was progressive drop-off throughout the remainder of the study. And they did test these subjects for urinary ketones, and they found that within the first 2 months of the study, the people on a low-carb diet, approximately 60% of them had detectable urine ketones, and then by the 3rd month, that had dropped off to something closer to 50%, but in general can give us a sense of the effect of the keto diet compared to a low-fat diet. And in both arms, the weight had decreased, but there was a greater change in weight in people who were on the low-carb diet. And then they looked at various markers on a standard lipid panel. And what they found was that there were increases in total cholesterol, in LDL cholesterol, and in HDL cholesterol that were seen in the study. And those increases were significant for the low carbohydrate group when compared to the low fat group. But there was also a significant reduction in triglycerides in this study. It's hard to mention the study without mentioning that they really, these participants were not given their meals. So they were given instructions on how to complete these diets, and then they were kind of largely on their own afterwards. But other studies have shown that LDL cholesterol can actually reduce. And this is a single arm study that was performed in Kuwait and enrolled people who had high BMI. And they were placed on the keto diet for 56 weeks. And they had about a 74% adherence by the end of the study. The important difference between this study and the last one that I showed you is that in this study, all meals were provided to the participants. And they kind of stratified these patients into 2 groups. They looked at the people who had high cholesterol, and then they also looked at the people who had normal cholesterol values. And just to go back one slide here, sorry, oh, maybe it didn't display, but in both groups, they saw a reduction in weight. I thought I had displayed that slide, but you can trust me that that was seen. And then they found that for both groups, the level of LDL had decreased. And this was a significant decrease when looking at the end of the study compared to the beginning. And they followed these people for 56 weeks, so quite a long period of time. And then in terms of what happens to LDL size, the keto diet seems to increase LDL size. And this is basically the only study I could find that had any comment on this. And it involved 12 normal weight patients. They were all men and they were all white and they were all placed on a ketogenic diet. They looked at the peak LDL particle size and the change in that. They stratified these 12 patients into 2 groups, which was people who have a pattern A profile, which is the one that's generally thought to be more favorable, and then people who had a pattern B profile, which is the pattern that's thought to be worse or associated with more harm. And amongst the people who already started off at pattern A, being on a keto diet for 6 weeks did not shift their pattern much, and there was no really difference in their peak particle size. But for people who started off as pattern B, what they found is that the LDL particle size increased by 3 weeks, and that increase persisted at 6 weeks of being on a keto diet. And so that sort of shifts them from having more of a pattern B to having a more of a pattern A profile. But this study just only looked at the increase in LDL size, and this was not attached to any type of outcome. And then the keto diet seems to improve some markers of insulin resistance. So this is a meta-analysis of 13 studies that looked at approximately 600 participants with type 2 diabetes who went on a keto diet. Again, some of the quality of evidence in this space is a little bit low, and that study from Kuwait I just showed you was included in this meta-analysis. But what we found essentially is that for looking at values of fasting glucose, whether you use a fixed effects model or a random effects model, that seems to be lower in patients who are put on a keto diet. Though when you look at other measures like hemoglobin A1C, that sort of association is not seen quite as clearly. So that suggests that the keto diet may improve some markers of insulin resistance, but across the board, it's a little bit unclear what happens. So now that we've kind of reviewed the keto diet, another popular diet that people have been implementing is intermittent fasting. So I want to move on to talking about what the effect of intermittent fasting is on cardiovascular risk factors. So intermittent fasting involves predetermined eating and fasting times. It has a few different forms. So the most common forms you'll hear about is the 16 and 8 method, which is where someone would fast for 16 hours out of the day, and then they have an 8-hour window each day where they can eat. There's the 5 and 2 method, in which 2 days out of the week, and typically non-consecutive days, you would eat less than 500 calories per day, and then you eat normally on the other days. And then there's the 24-hour fast version, where 1 to 2 days a week, someone will just complete a 24-hour fast. This diet has gotten quite popular because it seems to be a bit easier to implement than other diets and doesn't require quite as much prep work, but more being conscious about timing of eating. So there are multiple theories on why intermittent fasting is effective. So the first theory is that it affects oxidative stress, and that decreased intake leads the mitochondria to produce fewer free radicals. And that's based on a study of patients with asthma who were put on every other day fast, and they had decreased markers for inflammation over the course of that study. There's the circadian rhythms theory, in which dysregulation of the circadian rhythm results in increased risk for chronic disease. And that comes from some data that suggests, for example, having late dinners is associated with having higher postprandial glucoses, and also eating late into the night is associated with poorer sleep. And then the last theory on why this is effective is related to being in a ketogenic state. And since we talked about this at length just now, I'm not going to dive back into this. So in terms of what happens with weight loss, intermittent fasting seems to be able to potentially lead to weight loss. So this is a 25 person single arm study that was conducted in San Diego, and it was published as a pilot study. And what they did was they just had a single group. They screened them for a 2-week period of time and allowed them to eat basically at whatever regular time interval they were doing. And then they entered the intervention phase, which lasted about 12 weeks, in which they had a 10-hour time restricted eating window. The patients were enrolled in a circadian rhythm app, which is how they kind of interacted with the study. And then they had initial measurements of body weight composition. They did continuous glucose monitoring. There was kind of an activity observation phase, and then blood draws and vital signs. And then those assessments were then repeated at the end of the study. And so when they looked at the mean daily calorie intake, which was these participants were not provided meals, but then their meals were logged through the app, they found that there was a reduction in daily calorie intake once the patients entered the intervention phase. And with that, there was also a reduction in weight and a reduction in BMI, and that was statistically significant compared to the baseline or screening portion of the study. The same study then looked at what is the effect of intermittent fasting on LDL cholesterol, and what I took away was, in general, the effect on LDL is somewhat uncertain. And so when they looked at total cholesterol numbers, LDL cholesterol, and non-HDL cholesterol, they found that once the patients had entered the intervention phase, they had statistically significant reductions in those values, and that there was no effect on LDL particle number. But another study that enrolled 15 participants for 8 weeks of treatment. And in this particular study, each patient was its own control. So they were entered into the study for 8 weeks, having 1 meal a day. Then there was a washout period, and then they were then given 3 meals a day, and the calories were equivalent between these groups. They've kind of found the opposite. And so once people were in the 1 meal a day pattern or part of this study, that there were actual increases in the cholesterol, the HDL cholesterol and the LDL cholesterol when compared to the 3 meal a day portion. And intermittent fasting, when we look at LDL particle size, may show some improvements. So again, a small study looking at 35 patients who were put on alternative day fasting, meaning they fasted for every other day. Half of the patients were on a high-fat diet and half were on a low-fat diet. And they were in the weight loss phase of the study for approximately 8 weeks. And what we see is that in terms of LDL size, both arms had an increase in their LDL size. And then the percentage of LDL particles that were defined as being large LDL particles went up in both groups, and the number of small LDL particles went down in both groups. So in general, perhaps a more favorable shift in LDL particle size. And then looking at markers of insulin resistance, basically effective intermittent fasting is somewhat uncertain. So again, this is another study that looked at 8 obese men with prediabetes. Each patient served as its own control, and they looked at a feeding window of 6 hours compared to a control diet in which the feeding window was 12 hours. And in both arms, patients received 3 meals. So all the calorie counts and contents of the meals were the same, it's just the timing was different. And what they found was that in terms of mean glucose, there was really no statistically significant change between the 2 arms. But when we look at mean insulin and a marker, or kind of a composite of insulin resistance, there was a greater change in the time-restricted eating group as opposed to the control arm. And then this was also going back to that San Diego study. They also looked at markers of fasting glucose, fasting insulin, and hemoglobin A1C. And actually in their study, they saw no difference for any of these values. I would say the big difference between this study and the one I just showed you is that for the 6-hour eating window study where people were their own controls, they were provided all of their meals. And in this study, people were just interacting with this app, so they were responsible for all of their own meals. And then when I mentioned to some of you that I would be talking about intermittent fasting, some of you mentioned that it doesn't work. And that was because there was a study published out of UCSF recently that showed that basically looked at 141 participants who were randomized to having 3 meals per day or for having an 8-hour time restricted eating window. The app was fully conducted through a custom, or the study was fully conducted through a custom app, and all the participants were given a Bluetooth scale. 105 participants completed the study, and then 46 participants who were local to the San Francisco area completed 4 in-person visits. And the general adherence to this study was, I thought, overall pretty good for a diet study. So for the most part, 80 to 90% of people were adherent to their eating windows, if you will. And then there was kind of more drop off towards the end of the study. And then in terms of weight, there was a weight reduction in both groups. So people who had 3 meals a day and then people who had that 8-hour eating window. But when you compare those 2 arms to each other, there was no significant difference between groups. And then in terms of the 46 local participants who completed in-person visits, they had kind of more comprehensive assessments performed, including a number of labs and DEXA scanning. And what they found was there was no difference in the fat mass in fasting insulin, in glucose, and hemoglobin A1C, or in blood lipids between the groups. And sort of the important part of this study was that it was really, they were really only looking at time-restricted eating. So none of the participants were given any guidance on what sorts of diets to be on or whether or not they should be reducing calories. So now that we have kind of a better picture of lipids, of glucose, and of these fad diets, what happened with this particular patient. And so just as a reminder, at the last visit, he had increased his walking to 3 miles a day. He had stopped his statin as it felt like he was giving him diabetes, and that he had fully modified his diet to the carnivore diet, which we now know is a plant elimination keto diet. And in terms of his objective data, his weight actually had shown further improvements. His BMI was now 22 from being 26 when I had initially seen him. His hemoglobin A1C had remained stable at 5.3%. And then all of his cholesterol markers had really gotten substantially worse with this change. So his total cholesterol went up to 421 from previously being closer to 100 to 130. His LDL cholesterol went up to 335 from being closer to 60 to 70. And then his non-HDL cholesterol went up to 359 from being closer to 80 to 90. And then also interestingly, his his lipoprotein A level also went up to 143 from 78. And then he actually had quantitative assessments of his lipid subclasses performed. And what we find is that he generally was pattern A after switching to a carnivore diet, with the peak of his LDL occurring over where the LDL particles are larger. So this is generally, again, thought of as a more favorable subtype. And looking back, he had previously had this performed, and he was actually pattern A before, so he didn't really shift his pattern much. And so we talked about the test results extensively during that visit. And essentially, this particular patient was really committed to continuing this diet because of his improvement in weight and his improvement in insulin resistance. And what I didn't talk about is that he had been doing continuous glucose monitoring and really felt that the values were worth staying on the diet. He was fairly unwilling to restart a statin, so he was referred to lipid clinic for further discussion of lipid lowering therapies, and with a plan that he would come back to the next visit and we would have a frank discussion about whether or not he should be continuing on this diet at all. So to summarize what we talked about today, higher LDL cholesterol is associated with an increased risk of cardiovascular disease. And there's data showing that longer durations of exposure to high LDL cholesterol also increases risk of cardiovascular disease. The quantitative assessments of LDL, such as particle number or pattern, have an unclear association with cardiovascular disease, and they also have unclear clinical use. The elevated markers of insulin resistance are also associated with development of cardiovascular disease. And that studies of the ketogenic diet have demonstrated consistent results for weight loss and for improved triglycerides and HDL cholesterol. But the keto diet may or may not improve markers of insulin resistance and certainly has an unclear impact on lipid markers. And then intermittent fasting potentially has been shown to have benefit for cardiovascular risk factors, but then those benefits are likely more related to calorie reduction rather than any effect of the intermittent fasting in and of itself. And then generally, most studies in this space have been observational, or they've been really small numbers of participants who are followed with inadequate control arms or lack of control arms. And the diet protocols are really inconsistent study to study, with some participants being provided meals and some being left on their own. So ultimately, with kind of this level of evidence, making any decisions with our patients should involve some shared decision making as we advise them on how to proceed with any sort of dietary change. So with that, I thank you for all of your time and attention, and I really hope that this talk left you feeling more like this and not like this.